Good afternoon, everyone. My name is Dr. Jennifer Yost, and I am faculty with Health Evidence located at McMaster University in Hamilton, Ontario. It is my pleasure today to welcome you to our webinar where we'll be talking about overweight and obesity prevention from childhood to adulthood. This webinar today will provide a high-level overview of a number of systematic reviews conducted by the McMaster Evidence Review and Synthesis Center on the topic of overweight and obesity in children and adults. Before we get started today, just a few housekeeping issues. We would invite you to post your comments and questions during the webinar in the Q&A section at the bottom right hand of your screen. Please remember to send all questions to the host, please remember to send questions all, not just privately to the host, which is myself today. We will have a question and answer period at the end of the webinar in which I will pose your questions to our presenter this afternoon. In terms of connection issues, please remember to use a wired internet connection versus wireless for the best access to the webinar. And please note the 24/7 helpline for WebEx if you should need to contact them with any issues. So we have our first poll question today, and what we are trying to do is get a sense of how many people have actually joined in today. So if you could respond, whether it's just you, whether it's 2 to 3 of you and your colleagues, 4 or 5, or over to 5 of your colleagues, it would be most appreciated as we try to get a sense of who are the people that have joined us today. So I see many people are responding, so thank you very much for responding to this polling question. And while you're responding, we will go ahead and move on. I just wanted to take a moment to introduce our health evidence team. There's many of our staff and faculty that work to keep health evidence current and maintained. So just to provide those of you who may not be familiar with health evidence was launched in 2005. It is a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors per year with access to over 4,300 quality-rated systematic reviews or syntheses. And within these systematic reviews are included full text, plain language summaries, and podcasts where available. One of the main goals of health evidence, in addition to making evidence about effectiveness of public health interventions more accessible, is to make it easier for public health professionals to use evidence in decision-making. So our aim here overall at Health Evidence is to save your time in finding the best available research evidence regarding public health interventions, to provide you evidence that is current and relevant to your work, to be transparent about our process of including relevant systematic reviews and assessing them for their quality, providing additional supports for evidence-informed decision-making or the use of research evidence, along with other factors in decisions about programs and policies in public health, and ultimately making all of this easy to use. Here you will see a model for evidence-informed decision-making, which includes 5 components in this diagram. Traditionally, public health professionals and decision makers do consider evidence about community health issues and local context, existing resources, and community and the political climate in making decisions about programs and policies. However, it's become apparent in much of our work that considering evidence about research may be more challenging. So as such, Health Evidence in this webinar series has designed it to provide you with research evidence relevant to public health decisions. You also see here the stages in the process of evidence-informed decision making. And what we refer to as our EPH wheel illustrates the steps involved in evidence-informed practice. We find that the wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. We will hear today about how the McMaster Evidence Review and Synthesis Center has worked through the first 4 of these steps in order to help public health practitioners and decision makers with the remainder of the 7 steps. So we have another question for you here today. How many of you have heard about what we would call the PICOS format before, or the PICOS acronym? So many people are responding, and again, thank you very much for your response. I am seeing that it's probably about half and half. Half of those joining today are familiar with the acronym, and a little less than half are not familiar with the acronym. So just to review, as Health Evidence is committed to providing evidence about public health interventions, and today we will hear about some public health interventions for obesity and overweight in children and adults. The PICO format is a way to structure your questions so that it does make it easier to find the evidence for what you're looking for. And the P stands for the population or the situation. The I is typically the intervention, especially in regards to the evidence which health evidence makes available, but it also could stand for the exposure. The comparison is the other group, or what we would usually refer to as routine care. The O stands for the outcomes that we're concerned about, and the S stands for the setting. So we have another poll question for you today. So how often do you use systematic reviews, or what we may call syntheses or meta-analyses, to inform the programs and services in which you are involved? So always, often, sometimes, never, or for those of you, what a systematic review is may be new to you, and perhaps you might be selecting option E. I don't know what a systematic review is. Again, thanking everyone for their great responses, and I am seeing that probably with the group that's joining, most people can often use systematic reviews to inform their programs and services. So often and sometimes are the main answers that we are seeing today. So it is my pleasure to turn over today's webinar and introduce Dr. Leslea Peirson, a review coordinator at the McMaster Evidence Review and Synthesis Center. The Evidence Review and Synthesis Center appraises and synthesizes the latest data on clinical interventions, providing the Canadian Task Force on Preventative Health Care with state-of-the-art evidence summaries on which to base its guidelines. We'll turn it over to you, Leslea.
Okay, I'm here now, and I'm going to just slide you over to the next slide. So as Jenny said, I work for a group, and we call ourselves MERCY, or the ERSC, the Evidence Review and Synthesis Center. And we're one partner in a sort of a tripartite group that puts forward the information for guideline development in primary health care for Canada. I've worked with this group since 2010, so I've got 5 years of experience in doing different reviews. And the obesity reviews were a great part of the work in the last 5 years with 5 different projects. Our role, so our team's role in this process is to be an arm's length group from the task force that actually comprises or develops the guideline. And our job is to find and process the research evidence that gets used to inform the practice recommendations. So today what I wanted to do is, rather than pick children prevention of childhood obesity or treatment of adult obesity, we decided that we would offer you sort of a sampler platter of all 5 of our different obesity topics that we just completed recently. And then those of you who are more interested in a particular population or treatment versus prevention, you can dive a little deeper into one or more of those reviews at your leisure after the webinar. So I think this slide, the links that you have on this slide, I believe, take you to the health evidence summaries for each one of the reviews. And we've got 2 for children, child prevention and child management or treatment of child obesity, overweight and obesity. And then we had 3 for adults. And so in addition to what health evidence has put up here, we have the manuscript length articles for each one of these reviews, which I think if you go to the health evidence summaries, there's also a link for the PDF that takes you to Canadian Medical Association Journal Open that published the articles. The other place, which might be important for some of you, is if you actually go to the Canadian Task Force website, and that is canadiantaskforce.ca, so Canadian Task Force is all one word. They've provided the full technical reports for all of the reviews. So those of you who are really more interested in the granular detail might want to go there. And just to note that if you go in there, you want to go in as a primary care practitioner, not as somebody from the general public, because the reviews are only linked to the primary care practitioner part of the website. And then you scroll to the bottom and find all of the reviews. Let me see what else. I think I got to remember to switch the slides. There we go. Okay, so today we want to talk to you about 5 review topics that we did in obesity. Now, it's important to note that the topics and the questions of these reviews were decided on by the Canadian Task Force for Primary Health Care, not by our review group. So we are the evidence arm, and they're the decision makers. So we proceeded with the topics of obesity, and they came up with 5 review topics divided by population and by prevention, management, and we added a topic for the adults in terms of maintenance of weight loss. The key questions basically across all of these reviews are: what are the benefits and harms of behavioral and or pharmacological interventions? The nuances for each one of these reviews come through in the PICOS that Jenny was talking about and our inclusion and exclusion criteria. So we used a variation on the PICO formula to determine what counts as evidence for our reviews. And our variation, I call it a PIC dots. And this gets at the population, the interventions. We used comparators and study design. Then the OT is outcomes plus the time frame for assessing those outcomes and the settings. So the next slide is actually going to elaborate on what features were important for each one of these, our 5 reviews in these areas. So for populations, what we're dealing with here really is who are we interested in? And for the 5 reviews, we had 2 dimensions that we were looking at. One by age, so we had adults, and we had children and youth. And the other dimension that we looked at was by weight status. And what we began with for the prevention reviews was normal weight, in quotes, and then overweight or obese for the treatment reviews. Now, I think that some of the interesting things to note about these populations, so for the prevention reviews, we had to actually release our relax our criteria, I guess. When we started these 2 reviews, we were looking for evidence about interventions to prevent weight gain in normal weight populations. It was impossible to find studies that met our criteria for normal weight in the child prevention category. And for the adult prevention, we found one study. And so it was really important that we were able to find some evidence to help inform the guideline development. So we allowed for mixed weight populations in the prevention reviews. As long as there were some normal weight individuals, participants in the programs, then we were okay with using it, and as long as the intent of the intervention was to prevent weight gain and not for treatment of overweight or obesity. So that's kind of an important piece of doing some of the scoping background bits for the systematic reviews to give you a sense of what are you in for before you dive in and fully commit. So we were able to relax some of our criteria around the population for those reviews. Another interesting thing is about there's a difference in the age category for child prevention and child management. Clearly, you don't start thinking that there's a problem with children's weight until they age a little bit, so we weren't starting our child treatment reviews at age 0. We went from 2 to 18. We used the WHO growth charts as our measure for what constituted overweight or obesity in children, so we use the BMI greater than the 85th centile. For adult prevention, the age category 18 and over, so we didn't have an upper limit. We were interested in younger adults, middle-aged adults, and seniors. It didn't really matter to us what we were finding in the literature. Let's see. Oh, and I think for adult prevention, I think what's also important for you to know is that some of the differences you'll see in the products you have available to you, Health Evidence has, I believe their summary connects to the manuscript that we have in CMAJ Open for adult prevention, and the reviewers for that journal wanted us to stick to our original mandate of only studies that had normal weight populations. So we found one. So our manuscript for the journal actually addresses the evidence pertaining to normal weight and includes one study. The technical report that we did for the Canadian Task Force actually has 26 studies and includes mixed weight populations. So the research that I'm presenting today is primarily going to be connected to the task force, the technical report, rather than to the single study that is in the manuscript. Let's see. I think for the adult management, another key component is that we looked at overweight and obese, but we were not looking at morbidly obese samples. We did not include, as you'll see later, any surgical procedures or other more extreme weight loss weight loss treatment interventions. So we were within the BMI of 25 to 40. And then the adult maintenance category of population, what we wanted here was we wanted people who had actually been through an active treatment intervention, successfully lost weight in the treatment, and then were being randomized into an RCT that looked at weight loss maintenance interventions versus control. So that's what we were looking for our population there. Just a couple of notes about what we weren't interested or who we weren't interested in looking for, so our exclusions. We didn't include studies that had pregnant women or pregnant adolescents. We didn't look at studies that fully had populations of participants with eating disorders or other diseases where it predisposes people to weight gain, like polycystic ovarian syndrome. Let's see. I think that's probably lots of information for populations. In terms of the interventions, so this is talking about what people get. And it was important that the interventions were targeting weight loss. So the interventions were for the purpose of preventing weight gain or losing weight. And across the 5 topics, we were including behavioral interventions, and we put in there diet, exercise, combination of diet and exercise, or lifestyle interventions. When we got into the treatment interventions, we were also including pharmacologic or a combination of pharmacologic and behavioral strategies. We restricted our drugs of interest to orlistat and to metformin. In Canada, there's only certain drugs that are approved for weight loss by Health Canada, and so since our target audience for our systematic reviews was a guideline development group for Canada and for Canadian primary care, we limited our review to those particular drugs. What else can I tell you about? I think some people have questioned what do we include in lifestyle, and for us the lifestyle compared to the diet and exercise, if you have a diet and exercise intervention, it's a combination of what you eat and what you do. The lifestyle interventions address more factors and are more sort of comprehensive or holistic, looking at in addition to diet and exercise, alcohol consumption, sleep patterns, stress, all those and they could use counseling and education, social support, some environmental changes. So there was much more going on in some of the lifestyle interventions than simply eat these specific foods in this quantity and exercise in this way for this much time. What else did we have? I think that the other important things to note might be the exclusions. So what we weren't interested in, we didn't include faith-based approaches. Certainly interventions could be, you'll see in settings, it could be hosted by a church setting, but they couldn't be the faith-based approach. We didn't include surgeries or drugs outside of the metformin and orlistat. And we also did not look at any changes in the built environment as the intervention. So, for example, increasing parks or bike lanes in communities, or putting new water fountains in a school to increase water consumption. Those kind of things we didn't include. Okay. So if we think about the comparators, the next part of the PICO, comparator gets out who or what you're comparing against, your intervention against. And for us, we add that little subscript of design. So what kind of studies do we want to include? Do we think it's, we're going to allow for our evidence? So for these 5 topics, across all of them, for the benefits of the interventions, we wanted to find randomized controlled trials that provided a usual care, a placebo, no intervention, or a minimal intervention group. And a minimal intervention control group could be offered a newsletter or a single information session, say on healthy living or general health. That would be an acceptable control group. For also for the benefits, another design element that would be important is that we were requiring that there be 30 participants per arm of interest, so that it gets into things like power and sample sizes, so that we can understand the quality of our evidence. And so those of you who are familiar with the evidence pyramid or the hierarchy, the RCTs are the higher level evidence that allow you to have more confidence that the effect or the change that you're seeing is occurring as a result of the intervention. So the decision was that we wanted to go with this higher level evidence in the literature for our review. For the harms of intervention, if there's any harm at all, we want to know. So we weren't putting any sort of design or comparator restrictions on the literature. We were willing to take any study design with any type of comparator control group if they're reporting an adverse effect or harm of any of the interventions that we were looking at. So for outcomes, and time frame is our subscript. This is what's getting at what do you want to see happen or change, and over what period of time. So it's really what gets measured and when. And so some of my slides are going to get a little busier. I hope that's people can continue to follow along. So if you see along the first row of outcomes there, these are our benefits, and these are the primary benefits of the interventions that we were interested in. And because we were looking at weight gain prevention or weight loss, clearly our primary outcome is going to be weight. How it was measured was actually depending on the age category. So because the appropriate weight measures differ depending on whether you're a child and youth or whether you're an adult. So for the child reviews, our weight measurements that we were looking for were BMI, BMI-Z, or prevalence of overweight and obesity. For the adult reviews, we would accept change in kilograms, BMI, waist circumference, and percentage of body fat. In the adult treatment review, we also included a 5 or 10% loss of weight. The second row there is what we call secondary health outcomes, and our task force was interested in some other health indicators, things like changes in your lipids, your blood pressure, the glucose measurements, quality of life, physical fitness, so some secondary measures. One of the things to note is that in our review, we only collected data on these secondary measures in studies that also reported on weight. So if there wasn't a weight measurement in the study, we didn't include it. So it could be that there's a study out there that looked at a weight loss intervention, but it didn't report on weight. For some reason, it reported on the change in lipids. If it didn't have the weight measurement, it wouldn't be in our review. And then the third row is where we get to our outcomes of harm. And so the harms also kind of depend on the age and the focus of the intervention. So for the prevention-oriented reviews, we were looking at things like disordered eating and micronutrient deficiencies. For kids, of course, we're looking at growth and development as a harm, potential harm. In the treatment reviews where we have drugs, we're also looking at side effects of the medications. And when there's exercise, we'd also might be looking for things like exercise-related injuries, sprains, strains, bruises, those kinds of things. And what else is in here that's of interest? I think so a definition for what serious adverse event would be anything that needs urgent medical care or hospitalization. And I think the other detail that's important is the time frame. So we had put in restrictions in terms of when the intervention, or sorry, when the study had to assess the outcomes by. So for the child prevention studies, they had to report on outcomes that were measured at a minimum of 12 weeks post-baseline. For the child treatment review, the outcomes had to be assessed at a minimum of 6 months post-baseline. And you can see the timelines are quite a bit tighter with child reviews where children are growing and developing at a much faster rate. And then we have the adult reviews where our time frames were at 12 months post-baseline. Again, for the harms, since we want to know about any harms that happen, and harms can often happen in the moment of exercising and that kind of stuff, waiting 12 months for harms to happen. So we don't have any restrictions in terms of the time frame for any of those events. So in terms of the settings, this is getting at the context of the intervention. And there's a number of different kinds of things you could consider here. Because our group was doing systematic reviews to inform guidelines for primary care in Canada, then we were looking for primary care relevant interventions, we didn't go, for these reviews, we didn't go so far to sort of limit based on geography or country, but we did want to make sure that they were connected to the particular service health sector that was going to be using the review for the guideline. So typically in the manuscripts, what we've said is that the interventions have to be conducted in settings that are generalizable to Canadian primary care, feasible for conducting in or referral from primary care, and this means that they can be initiated through or they're feasible within a primary care setting, and they were or could be delivered by healthcare professionals such as doctors, nurses, psychologists, and dietitians. So in terms of the exclusions, we were excluding inpatient settings, institutions, schools, which I'll talk about in a second, occupational, so interventions that are run through through a work setting, and then interventions that relied on pre-existing social networks, so things that wouldn't be natural for a primary care physician setting. And I'll talk a bit about the fact that we use other reviews as our foundations for our searches. And in the case of the child prevention review, we used a Cochrane review, which included education settings as one of their features for their prevention interventions. And so since we used that particular review for our springboard, then we also allowed for education-based interventions in just the child prevention review. So those of you who know about systematic reviews and have done one, you know that the work is just starting, and we were just going to get busy now with our search and selection. The search and selection piece talks about what studies did we find. And so what happens is that, and this is again a busy slide, is when we have a topic, our group looks around for other systematic reviews that have been done that address the same questions, same topics that we're interested in, maybe slightly different. Because you don't want to repeat work that's already been done. That's not efficient. So we look for ones that are an exact match or the closest to our question. And if we run them through various assessment tools for systematic reviews, and we're confident that they've done a good job of their search and selection, that they haven't missed any studies that we might have included for our particular interests, then we can use their search and their included studies as a basis for our review, and then we move on from where they left off. And so most of the obesity reviews are basically updating the searches of other recent reviews by the USPSTF, the United States Preventive Services Task Force, and Cochrane groups. The exception is the adult prevention review, which we called a de novo search. We didn't find a review that did that focused on normal weight and that was asking the same thing that we were. So we started from scratch with that one, and you can see in that sort of the bottom left-hand corner, the de novo search started from 1980 and went forward. The other ones, we were able to put our search parameters for the search dates at the time that the other groups left off. So from, the prevention for children started with our search in 2011 to whatever date was, probably it was 2013. I'm trying to remember what our dates were. But we wouldn't have to have repeated all the work that these other groups have already done for us in the past. I think that some of the other interesting bits to know, let's see. So you can see here what happens is we go through a search, and the search identifies thousands, tens of thousands across all the reviews of citations, over 7,000 for the child prevention, over 2,500 for the child treatment, over 31,000 for the adult prevention, and as you can see, that those numbers just seem to add up. And so our group then has to go through all of those citations, and we do our work in usually in two independent reviewers go through the search and selection criteria together, independently, sorry, and then their answers have to agree. So the title and abstract on that over 30,000 studies brings us down to ones that we think we would like to take a look at in more detail, and that's where we go into the full text. So you can see how we brought down the child prevention from over 7,000 to just over 450 that we had to look at. We retrieve the full text, and then we take a more close look at the papers to see if they meet our criteria. And so based on that full text, which we also have two people do independently and come to agreement, then we get to our included studies. And so for the child prevention, we had 90 studies. For the child treatment, we included 31 studies. For the adult prevention, we had 26 studies. The adult treatment, we had 68 studies. And then the adult maintenance of weight loss, we had 8 included studies. You'll see that some of them have more papers than studies. It's because authors can sometimes report different outcomes in different papers. So we create what's called project accounts, and we can include all of the papers, but we group them under studies. So I think that's probably good for that slide. This next slide just is to give you an indication that our team works through a few different analytic processes that ultimately get packaged by GRADE, which is a system or a framework for assessing the quality of evidence. Some of you might have heard about GRADE in a different context. So there is GRADE for guidelines, and there's GRADE for systematic reviews. I mean, they work in tandem, but they are different frameworks. So one of the first things that we do is this risk of bias assessment for all of the individual studies, and then we go across the studies or bodies of evidence for each outcome. And when we have data that can be pooled, we run meta-analyses with any possible subgroup analyses on predefined categories that our task force has said they're interested in. So some of the examples of sub-analyses that we've done are based on the focus of intervention and behavioral versus pharmacological. We then also, for some of our outcomes, had a more granular look at the different kinds of behavioral interventions. So we looked at diet alone versus exercise interventions, diet and exercise as a category, and lifestyle. We also looked at, for the, say, child prevention, we looked at the differences between non-education, education only, and education plus other interventions. We found a way to a natural division between the duration of interventions at less than 12 months and more than 12 months. We looked at age groups, we looked at gender. For some of them, I think the adult treatment one, I believe we looked at baseline CVD risk status. We also did some comparisons on the study risk of bias rating to see whether there was any differences in outcomes depending on the methodological quality of the studies. One of the other things I didn't put on this slide that we do produce through our data extraction is we create these tables of included studies with all the characteristics of the studies, but also the interventions. So there's, in our technical reports, so not, well, I think that actually in the published studies, there should be like supplementary online supplements that give you the study details. So there's sub-products of all these reviews that help you if you're interested in finding out exactly what participants were exposed to for each of the different studies and the different kinds. So what were the diet interventions that people experienced? You could go to those particular studies and get a better sense of what were the components that the interventions received. So I think that what I've done on the next slide is I've shown you some examples of these different analytic products. So again, because we're doing 5 reviews, we can't go in detail, but this, if you decide you're going to explore some of our products in more depth, then you'll have a better sense of what you're going to find there. So this is just one example of a risk of bias table. It's taken from the adult treatment or adult management review. And so when you're working with randomized controlled trials, a common risk of bias tool to use is from the Cochrane group, and that's what we've used to assess the methodological quality of our included studies. It looks at various dimensions, shall we say, things like randomization, the blinding of participants and personnel, some variations in reporting, and things like other risk of bias. And there we might look at the power of sample size, contamination of participants, say, in the control group that actually did get some kind of intervention. We might look at industry funding, which might not be such a big factor for these particular reviews. Baseline imbalances, so are our control group and our intervention group actually equally matched, where they're the same weight. That would be an important thing as our baseline BMI in both groups, similar or the same. What else do we do here? So you can, this is just the beginning. If this was from the adult management review, we had 68 included studies. So we would do the risk of bias assessment for every study. And then we would be looking at using these data by outcome and then possibly by subgroups within outcome. So what we would want to do is, if we were looking at the outcome of change in kilogram, and then we were only interested in the diet and exercise interventions, we could actually sort of pull all of the studies from this master table that had that particular outcome and that particular intervention, and we could then create a mini table and get a really good sense from looking at it what would our assessment be of the methodological quality of the body of evidence that we've gathered for that particular outcome and possible subgroup. One other quick thing to note about here is that we also, for assessing the risk of bias, we use 2 raters, and we have to have consensus between 2 of our team members that we've actually agreed on the methodological ratings for each one of the tools items. So another product is the forest plot. So when you can pool data that was gathered using similar or the same measures, you can create these lovely figures, and they're actually a tool for understanding the evidence, but it's really important that you be able to understand what it means. So you have to be able to read or interpret all of these different features of the plot. So if you do go in, the manuscripts have a few of the main outcomes, probably BMI, BMI-Z for kids, and then kilos for adults. But if you go into the technical report, you'll find many more of these figures. In order for us to be able to pool a study, to include a study in one of these analyses, they have to provide the data in a way that we can enter it into one of these analyses. So we need to know the sample sizes, and we need to know their pre-scores or their post-scores. It's not just so if a study just tells us what the overall effect was for their intervention, but doesn't give us some of that more granular bits of data, we then can't include that study in the meta-analysis unless you've got some other clues and you've got a really talented statistician who can help you figure out some of those numbers from the details that are provided. So in this example, this is also from the adult treatment review. This is for the outcome of loss of 5% of the baseline body weight. So what we've done here is shown you that the overall estimate of effect for behavioral and for pharmacological plus behavioral interventions, you'll see at the bottom there's a diamond in the bottom right corner. The risk ratio is it's the 1.77. So that's the overall effect. But then we're able in this particular figure to see that the behavioral interventions had a risk ratio at the top of 1.75, and then the pharmacological interventions are grouped below that. So I'm sure if some of you haven't seen the PICOS, you might not be too familiar with these figures either, but basically that long line that's going down the middle is the line of no difference. If one of the individual study lines crosses that, it means that the intervention did not have a significant effect. So what you want to see is a confidence interval on one side or the other of the line, so what that little dot in the middle of the line is the effect estimate, and then the confidence interval is the line on either side. The diamond is the pooled effect, showing at the peak of the diamond is the pooled estimate, and the confidence interval runs to the edges of the diamond. And some of you may be wondering why there's so many decimal points on these. It's a request of the task force that in some of our analytic products we go to that extreme, in part because some of the reviews look at wanting to know in the millions when they do the grades. They want to know how many people per million it's going to affect. So we need to get that granular detail. But for the most part, you're going to see it at 2 decimals. Okay, so the next thing we do is this assessing the quality of the evidence. So we assess the body of evidence for each outcome using this grade system. So in outcome groups, we make assessments across 5 different domains. We look at the risk of bias, so are there any methodological limitations or flaws? We look at the consistency of the evidence to see how much variation, direction, and size of the estimates. We look at the PICO for the directness. How well does the evidence that we've gathered actually match the intervention, the population, all that kind of stuff that we said we were interested at the beginning. We look at the precision of the data, so how many participants or events, do we have enough, how wide is our confidence interval, does it cross the line of no difference? And then we also can look at things called reporting bias. So we're looking at any indications that there might be some bias in the publications. So are all the publications really studies that are showing an effect, and where are the studies that might not have shown the effect? There are different statistical tests. That a funnel plot is something you might have heard of. That's something, and then an Eggers test is something that we also do. Typically, we need at least 10 studies to be able to run some of these analyses. So once we've had a look at those 5 domains, then these evaluations result in one of 4 quality ratings that reflect the degree of confidence that the available evidence correctly reflects the true effect of the intervention. So it's not that it's how well the studies were done, but it's the quality is talking about how confident are we that any future evidence would lead us to the same conclusions. So if we have a high quality rating, it means that the research we have in hand actually has got it right. We believe that. We're quite convinced of that. And then as you go down in ratings, your confidence in the true effect of what you've got in front of you is it goes down. Okay, so if you go into our technical reports, you're going to see these grade tables. And so basically on the left-hand side of the table, the quality assessment is where those 5 domains are covered. So the rows have the outcomes. So you can see there's the 5% weight loss overall. And then we break that down. We look at the 5% weight loss by behavioral interventions, and then we look at the 5% weight loss by interventions that provided pharmacological and behavioral strategies. So you can see for the overall outcome, we had 24 studies, and then it breaks down to the 11 studies for behavioral and 13 for the combined. The table then will tell you our assessment of all 5 of those domains. So you can see I've highlighted here that we typically had problems, or we assessed that there were some risks of serious risk of bias across the studies for this outcome. And there was also some evidence of reporting bias when we did our statistical tests. So that when you take those 2 concerns, they drop the grade quality rating to low, which is, you can see that connected to the other highlighted column at the right-hand side. So for 5% weight loss, our grade quality rating was low. The right-hand side of these tables provides all of the stats, and I guess it depends on whether it's a dichotomous or a continuous variable, what kinds of information you're going to see there. For this one, we had the dichotomous, and so for each one of those outcomes and subgroups, we've got the different numbers that you would like to see. Our group actually calculates the absolute risk reduction and the number needed to treat and inserts those into the tables. Okay. The other thing to note is you see all these little footnote things. So accompanying all these grade tables in our products, it's usually pages of very granular footnotes that explain all of our ratings and why we came to the conclusion we did for each one of those assessment criteria. So some of you probably have been waiting for this piece the whole way through, and that is some of the selected key findings from the reviews, and we've broken it up into a slide for children and a slide for adults. Let's see, if we look first at the child prevention, if you remember first that we were looking at mixed weight populations. The main weight measure that we looked at here was a BMI, BMI-Z. Cochrane groups also use this summary measure of effect. The benefit of using this combined outcome is that it allows us to combine BMI and BMI-Z scores, it increases the pool of available data, so it allows us to have more evidence behind this effect. There were 76 studies that provided BMI or BMI-Z in this particular review. So the standard mean difference was minus 0.07, and that translates into a small benefit if you're looking for an interpretation of that number, and a significant reduction also in prevalence of overweight and obesity. The grade ratings are what you're seeing, the VL, very low. So our rating for the assessment of the quality of that body of evidence in grade was very low. The secondary benefits that we were looking at for child prevention, I've only included the ones here that had significantly greater results, and that's for high-density lipoproteins and physical fitness. And there were very few, there were only 3 studies that we found reported on data for adverse effects, and those that did reported no were mostly mild or moderate adverse effects. So here we're looking at like one that reported on how the intervention might have affected body image and there was no difference. Another one said they looked and they assessed for adverse effects, found nothing. The last one had some exercise intervention, and they didn't give specific examples, but they said they were mostly mild or moderate, and likely injuries, bruises, sprains, strains, those kinds of things. So I think the key message from the child prevention review is there were statistically significant but questionable clinical importance of our findings, and whether or not the findings that we found for weight gain prevention could be sustained over time. You know, our time frame was only for 12 weeks. There was no difference across the intervention types, so in the behavioral domain of diet and exercise or lifestyle. But what we did find was making a difference was the setting. So what happened is that the interventions that were offered in educational settings showed a difference, a significant difference between intervention and control, but we didn't see the same difference for non-education or the interventions that combined non-education and education settings. So if we look at then the child management review, this is the interventions to treat overweight and obesity. We found that the assessment of the grade quality across this review for outcomes was all moderate quality, so that's good. There was a significant standard mean difference in BMI, BMI-Z. We had 30 studies that we used for that particular outcome. There was no difference between, we had 26 of the studies looked at behavioral interventions, and 2 were combined behavioral and orlistat interventions. There was no difference in the weight outcome depending on whether you were in the behavioral or the drug combined. But it is interesting to note that the behavioral intervention showed a medium-sized treatment effect in terms of lowered BMI, BMI-Z, and the drug studies showed a small effect. So there wasn't a significant difference, but there was a difference in terms of the interpretation of the effect size. The secondary outcomes, we found significantly greater declines or benefits for blood pressure and for quality of life. Again, the clinical significance is very small for these improvements or benefits. The adverse effects that were found were typically just gastrointestinal difficulties that were found more common in the youth who were taking the orlistat, so things like bloating and diarrhea. The number needed to harm that we calculated for these adverse effects was 3, with a confidence interval of 2 to 5. I think one of the key messages that we found from the child management review, that it didn't matter whether, let's see, we did find limited evidence on the combined behavioral and drug interventions, so we might want future studies to look more closely at that. But because there's no difference between the behavioral and the drugs and behavioral, then it's you might more often opt for the ones that don't require the pharmacological interventions. One of the things that we did find that although both individual and family approaches were had significant improvements, that the interventions that targeted the individual were actually showing significantly better results than interventions that targeted the family. And it may be that, well, I'm not sure if we came up with a lot of really good explanations for why those differences might have shown up. You know, it could be that the control over diet and exercise in youth populations is different than the autonomy that some children have over their activities and their food consumptions. Okay, so we're going to take a look at the selected key findings from the adult reviews. The grade ratings for this evidence was mostly low and moderate. Let's see, for the adult prevention reviews, remember for the technical report, we were using the mixed weight population, and so we had an indirect evidence pool here. We found 26 studies with the mixed weight that we were able to use to explore our outcomes. And at the post-intervention, there was significantly greater reductions or benefits across the weight outcomes. There was no subgroup differences on the type of intervention, the duration, baseline CVD risk, gender, risk of bias, or baseline weight status. The stabilizing weight and producing weight loss by the intervention was consistent across all of those categories. There were also significantly greater declines in some of the secondary health outcomes, total cholesterol, LDL, fasting glucose, and the diastolic blood pressure. Remember, again, that these outcomes were looked at only in studies that also reported on weight outcomes. Now, so these were statistically significant, the greater declines, but our clinical experts suggest that they're not clinically meaningful differences. And then in terms of adverse effects, we found no studies with data on any adverse effects of interest for the adult prevention group. The adult management review found significantly greater reductions across our weight outcomes, and these were also clinically important weight loss results. And so we had about 49 studies that we were using for this particular, for the weight outcomes. So we had adults who were in the treatment interventions were losing on a 3.02 kilos more than those in the control group. And so that's consistent across all of our weight outcomes. There was significantly greater declines in some of the secondary health outcomes. The total cholesterol and fasting glucose, those results were found to be better in the studies that use the combined pharmacological approaches than those that just use the behavioral. One of the important findings that we came across was that there was also a substantial decrease in the incidence of type 2 diabetes, and it didn't matter whether participants were in the behavioral or the pharmacological strategies. There were very few and minor adverse events for the behavioral interventions, and as with the kids, there was gastrointestinal difficulties experienced more commonly when the drug interventions were being taken, the active drug versus placebos. Let's see. For the adult maintenance review, we found there was significantly less regain and better weight loss maintenance in the intervention groups than the control. So what happened is when we looked at these both groups, both the intervention and the control groups regained weight, but the intervention groups regained less weight than the control groups. They gained 1.44 kilos less than the control groups. And there was 3 studies that included orlistat and behavioral interventions. They showed a significant effect for maintaining a 5% weight loss with an NNT of 8 and a confidence interval from 5 to 18. But we didn't find any effect of these weight loss maintenance programs for the 10%, maintaining a 10% or more weight loss. Let's see. So what, I guess the key message from here is that there is some benefit to those who have successfully completed prior treatment, active treatment programs to then take part in formal weight loss maintenance interventions to better maintain their weight loss or to prevent extra weight gain. Let's see here. So what you won't find, I don't think, in the manuscripts is any of this contextual detail. In the technical reports, the task force asked us to do a different component of the review, and it's a different search strategy, but we actually look for some other evidence that helps give some background for them when they're making their guidelines. And so what we do is a search, and we look for research studies with data that is relevant to Canada and to primary care. We use a 5-year search history to look at some different questions that they pose. What we found for the obesity reviews was a general lack of research with data on these topics, and there was no real surprises in what we did find. So we looked for information on differential findings for subgroups. And we did find for adults there were higher rates of overweight and obesity for Aboriginal, rural, and northern areas. We found for children there were higher rates in the lower SES groups. And we also found that there were, among newly established visible minority immigrants, they have lower BMIs than the general population. We look for resource implications and cost effectiveness, and some of what we found in the literature said there was the economic burden of obesity ranges from $4.6 to $6 billion a year, and that healthcare costs among people who have overweight or obesity combined are higher, their healthcare costs are higher than for the general population. If we looked for data on patients and practitioners' values and preferences, what we found is there's a complex decision-making process regarding whether people will choose to seek or access treatment services, and that some of physicians' personal attitudes about obesity can influence their practice in relation to their obese patients. We looked for risk assessment tools, and we couldn't find much. All we found was the Edmonton Obesity Staging System that helps to identify obese individuals at greater mortality risks. And the other point to make, I guess, is there really wasn't much out there to tell us about prevention. So our focus on, the differential findings, resource implications, values and preferences in relation to those 2 prevention-oriented reviews. So I think I'm going to turn it over here to Jenny back again.
Sorry, everyone, for that technical difficulties, me getting back here on the line. Just wanted to say thank you to Leslea for taking us through such a great overview of all of those systematic reviews. What we would like to do is ask you a polling question here, is do you agree with the findings of the review series? So thank you to all of those who are responding, and we are seeing a few responses come in, and people are mostly saying yes, that they do agree. A few are neutral, and a few strongly agree or disagree. But primarily people are agreeing with the with the findings. What I'd like to invite everyone to do now is to go ahead and please post any questions that you have for Leslea in the Q&A section, and I will pose those to Leslea as the questions do come through. So again, thank you all for responding to this question, and the majority of people who have joined us today do agree with the findings of this review series. So we will move on to ask Leslea some questions that have been posted. So Leslea, the first question I think is just a point of clarification, but for all of the reviews that you spoke about today, all of the results have been published and are available. Is that correct?
That's correct. So the CMAJ Open for the published manuscripts, and like I said, the Canadian Task Force website has the full technical reports.
Great. Thank you very much for that, Leslea. In the meantime, I would, while we wait for some people to post some questions, hopefully we will, oh, this is wonderful. Someone has posted questions, so I can keep my questions for a little while later. So Kira Bailey would like to know, can you say a little bit more about the child findings regarding success of individual versus family interventions? Does this have anything to do with the age of the participants, perhaps?
Sorry, I'm just looking for that particular paper so I don't confuse. Just bear with me 1 second. I think this was one of those surprising things that I guess we had thought that the family interventions might actually show up being more effective than the individual focused ones for kids, but so it becomes one of those things you have to try and explain. And maybe your poll people on the line, Jenny, have some explanations too.
Sounds good. We can ask them if anyone also has some experiences that might help to address Kira's questions. Please go ahead and post those in the Q&A. Leslea, are you available to take another question, or are you still trying to identify an answer for Kira?
I'm going to try and do both.
Okay, and we can always get back to you, Kira, with a more formal answer to your question if we're unable to do so at this point in time. There is another question, Leslea. Do you think that the interventions would be more effective if they were longer term? Often funding dictates program length.
So I guess the answer to that is a personal response that, yes, I think that because a lot of it was about establishing eating habits and exercise routines, which over the time would probably become more ingrained, except that I don't have the evidence to back that up because I'm limited in terms of the reviews to say what we found. And for the kids, we had a short time frame of 12 weeks or 6 months, and we didn't look at the long term. And what we did have a couple of studies. I think there was 4 studies that looked at outcomes a little longer, and they didn't find a sustained intervention benefit, but the interventions had ceased. So the idea would be that if your intervention has ceased, then your the support and reinforcement for maintaining those behaviors would have ceased also. Again, if there's other people out there who want to comment on that, I think it's appropriate.
Great. I'm seeing no comments to the 2 questions that have been posted, but sort of along the same lines in regards to the time period, one of the participants would like to know, what was the time period considered long enough for weight for maintenance of weight loss. So I think you just spoke to the time frame for children, but perhaps you could clarify if that was for weight maintenance or just weight loss, and if you could clarify the time period that was considered long enough in the review for adult weight maintenance.
Yep. And then
thank you, Leslea.
I'm looking again. I think what I needed was somebody to help me with all these papers. Yeah, so it's a good, because our adult maintenance, we took the longest available time point when we looked at the, so there was intervention length, some were 30 months, some were 12 months, one was 36 months, a couple were 6 months. So usually what happens with the systematic reviews, to make sure our data are consistent, we would have taken the immediate post intervention data, because that would be consistently reported across all of the papers. And so we would be reporting on likely for 1, 2, 3, 4 of the studies had 12 months, so we've been looking 12 months post-baseline. For 2 studies, it was almost 3 years post-baseline, and for 2 studies, it was only 6 months. Otherwise, you're getting into comparing studies that, like I said, the previous person had asked you, have stopped the intervention and the monitoring and the reinforcement of the weight loss management behaviors, and then measured again maybe 6 months or a year later. And unless all of the studies had consistently given the 6 months or a year later, we couldn't combine them. So does that answer the question, you think?
I would hope so. If that does not answer your question, please let us know. We do have sort of a response to this discussion about the length of the interventions, and we have a participant who's responded that they agree, they support policy and reinforcement has to be sustainable. Therefore, often these studies are also limited or short-term effects versus whether an intervention is effective, and focusing on behavior and not policy or environmental changes would likely to be important. So we also have another question from Lisa, and Lisa would like to know, did any of the studies in the review show the use of technology to support children, families, and adults?
That's a great question. And that's not something we would have teased out in our review. So what I'm wondering if you're looking for things like what do you call that, when you get a reminder on your iPhone and stuff like that, those kinds of technology that, and no, but I'm guessing there's probably some reviews that have been done that have looked at social media as an intervention.
Okay, thanks, Leslea. And more just about the specifics, I think, of the interventions. And Elsie would like to know, did you also look at the types of personnel involved in these studies? Behaviors are a lifelong and societal and family issue. And while you're formulating your response, I think that it sounds like people are having some great questions about what actually entails each of the interventions. And so I would recommend that if you are interested in, for each of these reviews, there would be a table of included studies which would provide some additional details about the components of the interventions. Mm-hmm. So Leslea, again, just back to you about, did the review look at any types of personnel involved in implementing the studies?
So you're right, in the table of included studies, we would have had information if the authors, again, when you do systematic reviews, you're limited to what, in our reviews anyway, what the authors write in their papers, and we would have noted whether it was delivered by primary care or a dietitian or a school nurse or something. So we would have identified who the delivery agent was in that table. We weren't asked to do any subgroup analyses based on who the intervention, like what role the interventionist assumed in the healthcare system, though that would be, again, another great cut at the data. One of the things, sorry, Jenny, you were talking, and it lapsed my brain when we were talking, but we also were asked to look at features of effective interventions. And I think why it lapsed is because what we did was we went and took the main weight outcome, and then for any studies, individual studies that showed a significant effect, we took that particular study and looked at all of the different features of it, from who delivered it to how long it was, who it was targeted, what components it had. And we tried to see if there was any similarities across those studies that showed a difference. And there was so much variation on all of the reviews that we weren't able to sort of pin it down to say that these, if you were trying to do this yourself, that these would be the 3 key things you must do in order to get results. So the research is not pointing to that specifically. So these complex interventions, as people know, they get, there isn't a magic formula.
Great, thanks, Leslea. And we have a question from Matthew Hudson, who would like to know, from a public health perspective, with regards to prevention, there seems to be little or no support for developing a prevention-based intervention for adults. Would you agree that this suggests greater resource / funding should be targeted towards children, with a greater emphasis on treatment and maintenance interventions for adults?
So that, to me, in my own personal opinion, that sounds like a rhetorical question.
Okay.
Yeah. So, I mean, I think, the emphasis on, so if we're looking at effects coming through, clearly seeing effectiveness of behavioral interventions that involve diet and exercise and our patterns and our behaviors related to food and activity, these are things that, become instilled and entrenched as children. Clearly, we were able to unlearn and relearn things as adults, but, our reviews didn't look at evidence related to adults who were overweight as children and difficulties or abilities in terms of weight loss in adulthood. I think that would be interesting. But the other point that he was making about, the lack of attention for prevention. So, yeah, personally, I believe in the preventive, always putting in investments in the front end of things. But, even when we were looking for interventions for normal weight populations, this is sort of the crux of it, is that, you're not going to, and sorry, I'm going to be blunt with language, I guess, that you're not going to find interventions, say, in schools for preventing weight gain in normal kids, and they say, okay, so all you kids here in the school who are so, quote-unquote, normal weight, you can come with us, and everybody who's overweight or obese, you have to sit over there and wait while we do this intervention or do something different, because, it doesn't work that way, and clearly the lessons about healthy eating and lifestyle are beneficial regardless of what weight status you are. But I also think, if you've got somebody who's quote-unquote normal weight, you're not likely to go and spend your time looking for a weight gain prevention program. It's going to be something that you're going to integrate as part of your own healthy lifestyle. It's not, so framing it as that may be the problem, and maybe we need to reframe some of it in terms of the prevention lens.
Great, thank you, Leslea. We have another question. Local adherence to child weight management programs is a problem. Did any of the studies reference how to best keep families and parents engaged in the programs or the interventions?
No, so we didn't get that far into the, it's quite possible those elements were described in some of the family-based interventions. We weren't extracting the data on that particular level. So I guess what I would suggest is that you go into the included studies and identify the ones, there's some tables that would tell you which ones were family-based. you could actually pinpoint those studies and then go and specifically look for family engagement techniques.
Great, thank you, Leslea. We did have a question, but I'm just waiting for a bit of clarification on that. I guess maybe I'll just pose a quick question here also to give people some additional time if they have one last question or that they would like to ask. I guess my question would be for those who have joined us today, what do you think might be a first step that they can do in order to start going through the rest of the steps of evidence-informed public health? So, you know, you've done a great job of the question and appraisal and synthesizing, but what do you think might be a first step that those of us on the line today can use moving forward to use these results in practice?
You're asking me, Jenny?
Yeah, what would you recommend? Yeah, based on everything that you synthesized and.
Well, and my fallback answer is when we did the media release for all the reviews is that I kind of said, well, I'm the bearer of the evidence, and the task force is the body that's actually digested the evidence and thought about it with respect to how to put that into play on the field of practice and in the real world. And so, you know, I had to defer to the guidelines in those groups who've actually done that work of thinking about how to apply. I mean, I could clearly say, well, invest more money in treatment and prevention and put more focus in the behavioral components as opposed to introducing the drug components, because our results speak to the fact that they can be equally effective without going for some of the more intrusive or intensive interventions that also carry some adverse effects. So there's some surface messages and some messages that I think that the evidence suggests that are fairly clear, but actually the nuances of how do you take that and make that real and important to the practice of public health, that's the engagement between the research and the practice, the integrated knowledge translation that has to happen with these kinds of evidence reviews. And some of what health evidence does in terms of starting the translation for people in the field, I think is important. So how did I do in terms of walking right around that question?
Great, thank you so much, Leslea. And I think you made a really great point that if you do go to the Canadian Task Force on Preventative Care website, there are some clinician summaries and some other tools that might help people to further take the first step into using the evidence that you've presented today. We do have one or two last questions here, and one question from Anne Swan is, educational settings were highlighted in your talk with respect to child prevention. Does this apply to all age groupings?
No. So, we only looked or allowed in interventions within education settings for the child prevention review, not the child treatment and not for adults. But we would have allowed in, so maybe the question is, was it elementary and secondary? In that case, yes. If it was preschool, yes. So as long as they fit, and prevention was 0 to 18, so if there are any school-based or education-based interventions that met our other criteria, for any age group up to 18, we would have included.
Great, thank you. And we have a question from Laura McLeod, and Laura would like to know, she understands that the review excluded changes in built environment surgeries, other drugs, face-to-face approaches. Do you know if the Canadian Task Force is planning future reviews to look at these areas of interest?
That I don't know. I'm sorry.
Okay. And one last question from Elsie DeRose, and she was wondering, I think you touched on this a bit, but perhaps it is a really nice way to close our webinar today, but just what were some of the features of success? If you could just maybe highlight those again. Possibly it came through in some of the subgroup analyses with respect to the results today.
So fairly high level, I think one of the key messages is that for most of the outcomes, and primarily the weight outcomes, the behavioral interventions were as good, sometimes better, than when drug interventions were combined. I think that some of the message about layering in the behavioral, so it's not just exercise. Exercise alone was not as effective as when the approaches combined, things like diet involved and then other lifestyle. So looking more at the multi-component or more complex interventions. There's some noting the limitations in our review for not having looked for studies that didn't have the weight outcome. So there are some marginal benefits for other health outcomes, but clearly the benefits for weight were demonstrated. I think there's my lack of comment, I think, about the features of efficacious. I think it speaks to the complexity of what goes out there, and that there's so many different things that people are trying and doing that we aren't going to have, a handbook that says this is the intervention. If you're going to run it, you need to do it, and it's going to work with all of these different groups. I think one of the messages is that we need longer-term studies, and we need studies that include sort of the long follow-up, so that we can see whether or not the weight loss gains are maintained, or weight gain prevention is maintained over time. So those would be some of the things that I would come back around to. And I'm still looking for that point about the, because I know we wrestle with the individual and family targeted stuff. So yeah, if that person can make sure that they put their question to the main line, the health evidence thing, I'll make sure I get back to them.
Great. Thank you so much, Leslea. And so just to return to the model for evidence-informed decision-making, I think Leslea has given us a really great understanding of the research evidence that we can use in public health to apply this evidence along with the other components of the model. So thank you very much, Leslea, for being here today, and thank you to the Evidence Review Center for having undertaken all of these reviews and all of the time and effort that went into this. And again, just some last thoughts. We thank you very much for joining us today. A copy of the presentation will be available at Health Evidence, and we will be posting the audio and the slides on our SlideShare account and our YouTube channel. And please do check back for more webinars that we will be conducting through October and November. So again, on behalf of the entire Health Evidence team, thank you to Dr. Peirson, and thank you to all those who joined in today. And this will conclude our webinar. Have a really great afternoon.